So when I teach students and residents about Parkinson's disease, I give them a little bit of a mnemonic. It's called TRAP. So TRAP stands for tremor, which is tremor at rest. R is for rigidity. A is for akinesia or slow movements. And P is for posture and gait changes. Now, not every person with Parkinson's will have all four symptoms. There's a good 30% of people with Parkinson's disease who never ever will have tremor. Even if they've had Parkinson's for 20 years, their hands won't shake. They will have the other symptoms, slowness, stiffness, and the like. So it's very much a clinical diagnosis that you have to be evaluated by somebody who's experienced with evaluating movement disorders. And they go through assessment of your history, your signs and symptoms, and then come to the conclusion whether you're having Parkinson's or not. Now, what causes these symptoms? There are areas in the brain, in particular, one area called the substantia nigra, or the dark substance. It's in the middle of the brain, in the midbrain. And the brain cells, the neurons in this area die out, and there's less and less dopamine produced over the years. What this lack of dopamine does over time is the brain is just neurons firing. It's electrical circuits connected in different ways. And there are two feedback loops in the brain. We call them the direct and indirect feedback loops that control your movements and your motions. When dopamine is low, one of these feedback loops becomes overactive and another becomes underactive. And that then leads to the cardinal symptoms. So a chemical deficit, lack of dopamine, leads to electrical changes in the brain, which then leads to clinical symptoms that we see. Now, if somebody has difficulties with excessive sugar, it could be diabetes. And the reason for diabetes is low levels of insulin. If they're given a shot of insulin, their high sugar comes down because insulin is the natural substance in the body that controls sugar. Similar approach to Parkinson's disease. You don't have enough dopamine in the brain. Let's try to replace the dopamine. And in fact, if you go to the ICUs, intensive care units, you can hook up an IV dopamine drip to somebody. And you use that if you want to raise their blood pressure, for example, you can use IV dopamine. But that same IV dopamine is useless for somebody with Parkinson's disease. It won't control their symptoms. And the reason is there's a blood-brain barrier. Between the blood and the brain, there is a line of cells that acts as a defense for the brain, but it also prevents certain molecules from going across, and dopamine is one of them. So we can't use dopamine directly. What we use is L-Dopa, or Levodopa as it's also called. It's a precursor molecule. It's a smaller molecule. It can cross the blood-brain barrier. And then enzyme systems in the brain convert Levodopa into dopamine. And then that is basically as natural as it gets in terms of replacing the dopamine deficit that has happened due to the pathology of Parkinson's disease. Now you might say, what's this thing carbidopa, levodopa, or what's this thing Sinemet? And I'll tell you a bit about what carbidopa, levodopa is, and indeed what Sinemet is. Carbidopa, levodopa is two drugs that together are called Sinemet. The brand name is Sinemet, the generic name is carbidopa, levodopa. If you use levodopa by itself, and in fact in the 1960s when it was first introduced, levodopa was used by itself. But the trouble with that is most of that levodopa was broken down into dopamine before it crossed the blood-brain barrier. And then it doesn't relieve the symptoms of Parkinson's, but it causes a lot of nausea because there are receptors in the gut that respond to this dopamine. And when they're stimulated, patients get sick to their stomach. They may even throw up. So the idea was to prevent the peripheral breakdown, to prevent the breakdown of levodopa before it can cross the blood-brain barrier and reach the brain by combining this drug carbidopa. And in fact, when you combine carbidopa with levodopa, you need about 1/6 as much levodopa for the same clinical effect, and which almost in the majority of patients eliminates the nausea as a side effect. So SIN in Latin means without. Emet in Latin, emesis is vomiting. So Sinemet, without vomiting. Clever name. That's the explanation for carbidopa levodopa. These days, we rarely use levodopa by itself. It's always carbidopa levodopa. And in fact, sometimes we might even prescribe additional carbidopa in patients, the small minority who do have trouble with nausea. Adding extra carbidopa can be helpful. Now, carbidopa levodopa, Sinemet, is the closest thing there is to a cure in a sense. I mean, imagine if somebody came out with a tablet of insulin. You know, you would think of it almost as being a cure for diabetes. So easy to take. You take it, your sugar is controlled. We don't have that for diabetes. We have that for Parkinson's. But what we find is when we use levodopa, not just for a week, a month, a year, but long term, there are some challenges to using the medication. The most important thing is that levodopa is very short acting. The half-life, meaning 50% is gone from your blood, is just 1 hour. So it's very short acting. There is the attempt to extend the duration with extended release formulation, Sinemet ER or Sinemet CR as it's also called, but really it doesn't do all that much in increasing the duration. It starts late and ends late rather than truly prolonging the duration for which levodopa works. This short half-life also has an impact on the receptors, the dopamine receptors in the brain. And because they are exposed to a pulse of levodopa, then nothing, a pulse of levodopa, then nothing, it changes the receptors themselves, and then that can lead to on-off fluctuations and dyskinesias. In fact, if you follow patients, if you follow a cohort of, say, 100 patients from diagnosis onwards, you'll find by the 5th year, about 50% of them will have on-off fluctuations or dyskinesia. So that is the challenge of levodopa. Now, can we make levodopa work better? We already talked about carbidopa. It prevents peripheral breakdown, so you need less levodopa than you otherwise would. Sinemet ER is another option. Rytary is a newer wrinkle on that. 1 part immediate release, 4 parts slow release Sinemet combined into one package, and that can increase the duration to some extent. We oftentimes might add a medication called Comtan. It's also called entacapone. So there are 3 or 4 drugs. Tolcapone was the original one, entacapone, and now there's opicapone. In the Chicago area, we also had Alcapone, but we don't use that for Parkinson's disease. So entacapone blocks COMT, which is catechol O-methyltransferase. This is an enzyme system not in the brain, but in the gut. And by blocking COMT, you allow more levodopa to enter the bloodstream, and so more can reach the brain, and so you have a longer duration of action. Another way to do it is to use a levodopa gel through what is called as a Duopa pump. And I've used these Duopa pumps in my practice in few patients. But the problem is it involves essentially putting in what looks like a feeding tube. You know, when you have trouble swallowing, people put in a feeding tube to maintain your nutrition. This is something like that, except there's an extension that goes on into the small intestine from the stomach. And the challenge with this has been it's very difficult to keep patients using the tube because there's always some twisting of the tube or some other complication. So it's not been very satisfactory in my practice to use this. What about alternatives to levodopa? The first category is called dopamine agonists, so pramipexole or Mirapex, ropinirole or Requip. There's also a patch called rotigotine or Nupro that can be used. These work on the dopamine receptors but have a much longer half-life. So for example, pramipexole, the half-life is about 6 to 8 hours, as opposed to the 55 minutes to an hour of levodopa. We can also use monoamine oxidase inhibitors, selegiline, which is available as Elderpril or Zelpar, Risagiline or Azilect, safinamide or Xadago. All of these are ways of extending the on-time, extending the duration of levodopa activity. There is a old-fashioned group of drugs that are called the anticholinergics. Artane or trihexyphenidyl, cogentin or benstropine are belonging to this class. We generally don't use these first line because they can cause a lot of dry mouth or blurred vision, or even trouble with bladder outflow, or sometimes confusion. But sometimes these can be helpful, particularly in tremor predominant patients. So adding trihexyphenidyl to Sinemet can sometimes help control tremor better than Sinemet alone. There's also a class of drugs called glutamate antagonists, and we use these mainly to control dyskinesias. The main one that we use is amantadine, but there are some newer drugs we'll talk about in a bit in this class as well. So if you follow patients from diagnosis and you keep following them every 3 months, every 6 months for 4 or 5 years, you'll find by the 4th year or 5th year, patients will say, you know, my 8 a.m. dose, it used to last all the way till 12 noon, but now 11 o'clock and I get more tremor, more stiffness, I have a harder time walking. And it takes 30 minutes for the next dose to kick in, and only then do I feel normal again. So that is an end of dose wearing off. It tends to be predictable. Some patients can set an alarm clock as to when they're going to go off. It can be that predictable. But as time goes on, these fluctuations become more and more random, more and more sudden. Patients can also have dose failures. Their 8 o'clock dose kicks in fine, but their 12 o'clock dose does not kick in at all. And they are frozen stiff. They have trouble getting out of a chair. They have trouble walking. They're shaking like a leaf. And it's only the next dose at 4 o'clock that kicks in and gives them relief. So this is called a dose failure. A lot of patients will have morning akinesia. So first thing in the morning, they will be stiff and slow. They might have trouble walking. They might be at risk for fall even, or late at night as the levodopa wears off, they might have similar trouble. There's also a tendency as the disease progresses to have an interaction with protein in the diet and the levodopa, and this can lead to dose failures and on-off fluctuations. And then finally, some patients become literally, in a sense, dependent on levodopa. So when the levodopa is wearing off, not only do they have physical symptoms, they may have a lot of anxiety all the way to full-blown panic attacks as the levodopa is wearing off. So that's a dopamine dysregulation syndrome. In addition to these wearing off sort of events, patients can also have dyskinesias. If you've seen Michael J. Fox on TV, he has this writhing, jerking movement that's called a dyskinesia. And again, there are different types of dyskinesias. The most common is peak dose. So as the medication is at its high, you will get the dyskinesia. But sometimes some patients will have end of dose dyskinesia. As the medicine is coming down, they start to get the dyskinesia. Some patients will have what is called as a DID phenomenon, dystonia, improvement, dystonia. So at the very beginning, their feet might cramp up or their toes might curl under, and then they'll get a good on time. And then as the medication is wearing off, they will again get these dystonic spasms, or they may be dyskinetic at the beginning, then have a good on time, and then dyskinetic at the end. So different presentations, and the management of all of these is different. So one of the things that we have started to use more and more, in addition to your baseline levodopa or levodopa in combination with other medications, we have started to use what are called as rescue medications. So the sort of patients who might need rescue medication are those patients who are having wearing off, and even though you increase the frequency of levodopa, they don't respond, or they have sudden and random off states, or they may have protein interactions with the dietary protein and the levodopa. Or some people, you know, from an occupational standpoint, especially younger patients, you know, they don't want to be seen in a meeting shaking and having tremor. They want good control that has a very quick onset. So for that, we consider using rescue medications. One of the earliest is apomorphine, which is available as Apokyn. And in fact, if you look at the history of treatment of Parkinson's, apomorphine was used in the 1950s before levodopa. It has nothing to do with morphine. It's not a narcotic. You don't get dependent on it. It's apomorphine. It stimulates the dopamine receptors, and it's given through an injection. It's sort of like an EpiPen. It's packaged like an EpiPen, but it has a very quick onset of action. Within 10 minutes, the patient will go from an off state where they might have trouble even getting out of a chair to near normalcy with good control of Parkinson's symptoms. The duration is about 90 minutes, so you can't use Apokyn by itself. You will have to combine it with Levodopa. One of the limiting factors with Apokyn is in some patients it can cause orthostatic hypotension, meaning their blood pressure when they stand up can drop quite a bit to the point where they may feel dizzy or they may even have a blackout. So we insist on doing the first injection under our observation in clinic when we are starting patients on Apokyn. A new wrinkle on this, which is brand new, just released, is called Kynmobi. And what Kynmobi is, it's the same apomorphine, except they've packaged it now not as an injection, but as sublingual apomorphine. So if you've used Listerine wafers for bad breath and the like, you put it under the tongue, it dissolves, it releases the Listerine. This is very similar. It releases apomorphine, and the sublingual absorption is actually quite reasonable, and the onset not quite as quick as the injections, but still within about 15 minutes, the patients start to notice a difference. By about 60 minutes, they will have the peak effect, and then the wearing off starts in about 90 minutes. Patients might have some local irritation in their mouth. That's something that is a side effect to watch out for. But again, a good way to use a rescue medication in patients who have sudden off states or protein interactions and the like. Another new kid on the block, another new development is inhaled Levodopa. So instead of taking the Levodopa as a tablet, you use this inhaler. It's called Inbrija, and it's similar to asthma inhaler. So you take 2 puffs of the Inbrija. The onset is within 20 minutes. It lasts for about 60 minutes, a little longer than that. Since it's an inhaled product, it's a powder that is inhaled. Sometimes some patients can have a cough as a side effect. There are a bunch of other newly released medications for Parkinson's disease. Estradiol or Neuroscience is one of them. This is what is called as an adenosine 2A receptor antagonist. So I talked about dopamine at the very beginning, but there are systems that modulate dopamine, and estradiol works on the adenosine 2A receptor system that modulates dopamine. And Neuroscience can also reduce off periods without causing an increase in dyskinesias. I worked on this in research when I was at University of Chicago almost 12 years ago. And the challenge with this medication, from what I recall from the trials and indeed in using it now that it's been released, a lot of patients have cognitive side effects, sudden drowsiness, confusion, and things of that sort. So it's not been the easiest medication to use, but in a subset of patients, it can be very successful. Another new kid on the block is extended release, not amantadine, but it's a COMT inhibitor called Ongentys. And this, again, is similar to Comtan in that it can extend the duration of action of Levodopa, but headache and musculoskeletal pain can be side effects of this medication. Coming to extended release amantadine, there are 2 drugs very similar to each other, Gocovri and Osmolex, which are also brand new. And as opposed to giving amantadine 2 or 3 times a day, this is a single dose, usually given in the late evening or at night, and it starts to kick in the next day. And this can help reduce dyskinesias, the involuntary movements that some patients will have as a side effect of Levodopa. It can cause anticholinergic side effects, dry mouth, blurred vision, and the like. So that is something to keep in mind when you're taking this medication. Now, we talked about the cardinal symptoms, the TRAP symptoms, the tremor, stiffness, slowness, trouble with walking. But that's just the tip of the iceberg. There's a whole host of symptoms. We call them non-motor symptoms, and these can be just as disabling as the physical symptoms. So I'll talk about these one by one: orthostatic hypotension, sleep disorder, depression and anxiety, hallucinations and delusions, excessive salivation, and dystonic pain. So orthostatic hypotension. Orthostatic means on standing up. So their patient's blood pressure might be normal when they're lying in bed or sitting down, but the minute they stand up, they feel dizzy, they black out, they might even have a syncopal episode. And this tends to be more common with atypical Parkinsonisms like multiple systems atrophy. But as the disease progresses, once you've had Parkinson's for 5 years, 7 years, many patients will have some amount of orthostatic hypotension. So to manage this, step one is to talk to your primary care and see if there are some blood pressure medications that you're on that could be eliminated, because that itself can be very helpful. Adding salt to the diet. Most patients, 55 plus, we say restrict salt, don't add salt. Parkinsonian patients, on the other hand, when they're having the symptom, they would benefit from extra salt, being liberal with salt intake. In fact, even using things like Gatorade or V8 tomato juice or even salt tablets can be helpful. There's also medications that can help. Fludrocortisone, midodrine, and Northera are 3 of the medications that we use for this problem. Sleep. I was told by Beth that this was a question that comes up often, sleep disorders and Parkinson's. And I wanted to explain the mechanism as well as what we can do in order to control and treat this problem. Interestingly, sleep disorders can be predicting Parkinson's disease onset by 7 to 10 years. So patients might actually present with sleep issues because the Lewy body that is going to hit the substantia nigra 7 to 10 years from now is already hitting the area in the brain that controls sleep, and that's called the magnocellular nuclei in the brain. So patients with Parkinson's often get what is called as a REM behavior disorder. REM sleep, rapid eyeball movement sleep, is basically the sleep where you're dreaming. But most people, when we are dreaming, when we are in REM sleep, we have what is called as REM atonia or paralysis. So your body is completely immobile for that half an hour or hour of REM sleep. So even though, there's a villain in your dream and you're giving him a good solid punch, your body is completely relaxed and nothing happens other than in your dream. But patients with Parkinson's, because they lose this REM atonia, they are not paralyzed in that REM sleep. And guess who gets the blow? Not the villain in the dream, but the spouse right next door. So unfortunately, that is very common. Patients themselves, they might be jumping from a fire in a building, and they might jump in their dream, but if they lose this REM atonia, they're jumping from their bed. And I can recall at least 7 to 10 patients who had that happen, and then they had a little hip fracture or some other injury. So controlling this REM behavior disorder is really important in order to have a good night's sleep. The other issue that you can get because this disruption of the sleep cycle is excessive daytime somnolence. So night becomes day, day becomes night. The patients are awake at night, very disruptive to the spouse, and come daytime, they're drowsy. So again, controlling sleep, having a good night's sleep, very important. Step one is always non-pharmacological. You don't want to prescribe away everything. You want to start with good sleep hygiene. So no TV, no computers, no tablets after 7 p.m. In fact, even in my household, I realized this whole social media issue, especially after a night like the debates that we just saw. I think what we have agreed to as a family is we have our charging stations outside the bedrooms, and the phones and all are charged outside. So when we go to sleep, we sleep. We're not waking up at 2 a.m. and putting something on Twitter. So I think it's very important. Good sleep hygiene is very important. The bedroom should be free of all devices, phones, iPads, and so on. Avoid caffeine, whether it's coffee, tea, Coke after 5 p.m. Try soft music, white noise, meditation, prayer, whatever you feel like in order to calm your mind down. It's very important. Occasionally, the sleep disruptions might not be Parkinsonian, especially in patients who have some amount of obesity. You have to consider sleep apnea, and then getting a sleep study can be very helpful because, and especially if your spouse notices that you're having sudden arousals during sleep, or if they notice you're snoring a lot during sleep, it might be worth talking to your primary care physician, getting set up for a sleep study, because you might be having sleep apnea. And not only is this a disruption to sleep, but it raises the risk of you having heart attacks and strokes. So it's worth getting treated. One of the things that, based on the story I told you about hip fractures and the like, consider moving from the beautiful high 4-poster bed that you have that is a mile away and that was designed by King Louis XIV to avoid snakes from crawling into his bed, into one of those modern beds that are very low on the floor. So even if you do jump off the bed, you're not going to hurt yourself in that sense. So consider that also if the REM behavior disorder is getting to be a bothersome issue. In terms of addressing it with medications, again, my first line of treatment is melatonin, 3 milligrams to 10 milligrams about half an hour before you go to bed. But there's also a sublingual melatonin that dissolves underneath the tongue. Now you have to remember, when anybody with or without Parkinson's goes to sleep, there's a gland right in the center of your brain called the pineal gland that releases, guess what, melatonin. And that then flips a switch in the brain that converts you from being awake and alert to drowsy and sleepy. And melatonin is the compound that allows you to flip that switch. So melatonin is a good first line treatment. The tablet form you would take to go to sleep, but you might also want to keep a little sublingual dissolvable under the tongue tablet by the bedside. So if you wake up at 2 a.m., don't go searching for the television set or your iPad. Put that melatonin sublingual underneath the tongue. Try to do some controlled breathing, and within 5 or 10 minutes, you'll go back into your second round of sleep. That can be very helpful as well. We do recommend avoiding the traditional sleep medications, benzodiazepines, Ambien, and Lunesta, and so on. One issue with these medications is somnambulism, sleepwalking. And the combination of the medications, the levodopa wearing off, patients being stiff, slow, having poor balance at night with somnambulism is a disaster waiting to happen. A lot of times these patients will fall and break a hip and so on. So that's one reason to avoid these medications. They also affect your balance. They increase the risk of cognitive decline, including dementia. If you're using them long term, there's a high risk of dependence. So if you're using them for a day or two, you've been through some really stressful news at work or in your family life, and you need a little Ambien or Lunesta for 2 or 3 days or maybe a week, it's reasonable. But if you're taking it beyond a week, you're going to go down that slippery slope where you start to get more and more dependent on it, and then you're going to deal with these long-term side effects. Depression and anxiety can, just like with the sleep issues, they can precede the diagnosis of Parkinson's by many years. We talked about magnocellular nuclei in the brain being affected with sleep. In the case of depression and anxiety, there's a nucleus in the brain. It's called the locus ceruleus, which gets hit by the Lewy bodies. And then no matter how well you treat the Parkinson's with dopamine and dopamine-like drugs, it's not going to make the patient feel any better because they're so depressed. They don't want to get out of bed. They don't want to do anything. They don't want to participate in activities with their spouse or even for themselves. So it's non-dopaminergic. It has to do with serotonin. It has to do with noradrenaline, and you have to treat that separately. Again, start non-pharmacological. Don't ask for a prescription for everything. Start with non-pharmacological methods. Music, wonderful antidepressant. Physical exercise, very, very helpful. Social engagement. You're just seeing you're engaged in social engagement right now. COVID has trapped us all in our homes with good reason. We have to keep ourselves safe. But use Zoom or use FaceTime. Talk to your friends, your family on a regular basis, because that is a very good antidepressant right there. Meditation, guided meditation or otherwise can be very helpful. A good diet can be very helpful as an antidepressant. In fact, the diet we recommend overall for Parkinson's, it's called the MIND diet. It's a variant of a Mediterranean diet, can be a very good antidepressant. But in a lot of patients, we do have to treat them with medications, and they're called SSRIs, SNRIs. And sometimes we may ask our colleagues in psychiatry to help us out when the depression gets strong enough. Hallucinations and delusions. People have started seeing these ads where the person with Parkinson's sees the little bunny or things of that sort. That's an ad for pimavanserin or Nuplazid. I do think this is an issue in patients with Parkinson's. It should be raised by you with your physician and treated relatively early in the course of the disease. But don't be alarmed by those ads. Not every Parkinson's patient is going to have this issue. If it happens, get it treated. For the spouses, one thing we have learned is, let's say somebody is having a hallucination that their dead brother is in the room with them. The tendency of the spouse is to say, no, don't you know, so-and-so died in 1970 and he's not here anymore. And then there's a whole conflict that is set up. It's better to distract. Don't change the subject. Talk about something else. Talk about the ball game. Talk about the new movie. Don't engage in a debate, because that then creates a lot of agitation and anxiety. Again, pimavanserin or Nuplazid is FDA approved to treat this. Psychiatric referral sometimes might be needed. But one thing very important to remember, if somebody who's otherwise cognitively doing very well, even after having Parkinson's for many years, if they suddenly decline over the course of 2 or 3 days, one of the things to keep in mind is they might have a UTI or some other infection. And that might be the explanation for their sudden decline. So talk to your physician, get screened with a urinary analysis, a CBC, a chest x-ray, depending on your symptoms, because that might be the mechanism that is causing that confusion. In my practice, I will often ask for an EEG. We put these electrodes on the head of the patient and look for spike waves in the brain, because the Parkinsonian brain tends to be irritable. We think of seizures as being convulsions, frothing at the mouth, jerking, all of those things, and that's a full-blown, quote-unquote, grand mal seizure. But a lot of Parkinson's patients or dementia patients can have complex partial seizures, which can present with just brief episodes of confusion or difficulty with focusing and the like, and an EEG can be very helpful to look for these kind of issues. Another very common, very troublesome symptom, non-motor symptom, is excessive salivation or sialorrhea. As the disease progresses, patients lose their swallowing reflexes and the saliva pools in the back of the throat. And not only does it cause cosmetic issues with the drooling, but it can also lead to coughing episodes, choking episodes, aspiration pneumonia. So it needs to be treated. There's a medication by mouth called glycopyrrolate that we will use, but probably what works most effectively is a type of botulinum toxin or Botox called Myablock. We inject the patients in our office, no anesthesia, no special preparation required. It takes me 10 minutes to do that. It's 3 mosquito bites on one side of the cheek, 3 mosquito bites on the other side of the cheek, and the injections are good for 3 to 4 months and can really prevent a hospital stay from a pneumonia, and it's well worth doing. Another thing people don't talk about in the context of Parkinson's is pain. And people with Parkinson's have pain for many reasons. They could have arthritis in their back, they could have spinal stenosis, other things, but sometimes it is directly an effect of Parkinson's. It's called a dystonic pain. So you can have cramping in the calf muscles, you can have curling of the feet, but you can also have low back pain. As the medication wears off, these muscles tighten up, and that can lead to severe spasmodic pain. Again, Botox injections, depending on which area is involved, whether it's the neck or the back or the calf muscles, can be very helpful in reducing this pain. So we've talked about motor symptoms, we've talked about non-motor symptoms. What about further progression where things get complicated, where the response to medications is not adequate? Typically, around about the 5-year mark or the 7-year mark, we start to have these discussions about surgical treatment. There's more than one way to do it. The old technique is called pallidotomy. A newer wrinkle on that is MRI-guided focused ultrasound. And probably the gold standard surgical treatment right now is deep brain stimulation. So pallidotomy, when I was training at Columbia Presbyterian in New York, this was the go-to surgical treatment where you actually target the area in the brain called the globus pallidus, and you make a small stroke in that area. You have to drill a burr-hole, put a probe in, and through that probe, basically heat up that area of the brain to create the stroke. That area in the brain, the globus pallidus, is overactive. And this can create muscle stiffness, slow movements, dystonia, and it also has tremor cells. that can lead to tremor. So making that lesion actually helps the patient. The challenge with pallidotomy, which we found, was that if you have a side effect, you've made a stroke, there's no turning that back. So the side effects are permanent. The optic nerve is very close to the ideal target. So sometimes not only do you hit the globus pallidus, but the heat spreads to the optic nerve. And then patients will have field cuts. One side of their vision will be blocked out. When you do a lesion on one side of the brain, the patients benefit and do well. But when you do a lesion on both sides of the brain, they may have severe troubles with speech or swallowing or memory issues. So bilateral lesions are not well tolerated. And over time, the effect fades away and you can't adjust it. It's a one-time procedure. And typically by the third year, patients are returning back exactly where they were. So we have given up pretty much on pallidotomy. It's very rare that we will offer that these days. There's a new wrinkle on pallidotomy. It's called MRI-guided focused ultrasound. I'm involved with research into this technique. There's an Israeli company called Insightec. The technology is called Exablate. We are one of 15 centers in the world that are doing it. Major university centers, University of Pennsylvania and so on, are also involved. We are actually the #1 center right now in the world that are doing this procedure. And the idea is very similar to pallidotomy, where you are using ultrasound waves to make that lesion. The advantage to pallidotomy is, over pallidotomy, is there's no burr hole involved, there's no lesion involved, there's no incision involved. In fact, you're not in an operating room. You're having this done in an MRI suite. Right now, the FDA has approved a target in the brain called the thalamus that patients with tremor benefit from. So if you have essential tremor, or you have a friend with essential tremor, they might benefit from focused ultrasound of the thalamus. But it's not so helpful for Parkinson's, because even though your tremor might be better, you might have more trouble with gait and balance and the like. So it's not a good target for Parkinson's, whereas the globus pallidus is a good target. That's what we're researching right now. So again, it's performed in an MRI suite, not in the operating room. There's no surgical incision, but again, it does involve making a stroke. And again, side effects can be permanent. You cannot offer this to patients who are on a blood thinner or pacemaker. There's no adjustment to keep pace with the disease. So I think this is going to be a complement to DBS. It's not going to be a replacement for it, but in the trial, as we've been working on it so far, there certainly seems to be promise. Deep brain stimulation is the gold standard of surgical techniques. The ideal target in the brain, in our practice, we have found is the subthalamic nucleus, a deep area in the brain. We would never ever dare to make a lesion in that area of the brain, because that is very expensive real estate. The centers that control your breathing, that control your heart rate, are right around there, and we are not going to make a permanent stroke-like lesion in that area. On the other hand, it's quite safe to put a wire down and to modulate the brain nuclei in that area. And to improve the accuracy, we use a method called brain mapping, or MER-guided targeting. So I actually listen in for about 3 to 4 hours to those brain cells to map out different areas of the brain to find the best target, so that we can control those symptoms better. Some of the new advances with regard to deep brain stimulation that we have started to use, one is directional electrodes. So just like with real estate, it's all about location, location, location. And what the directional electrodes allow us to do is to literally steer the current to areas of the brain where there's excessive activity, and to avoid the areas that cause side effects. So that has been a big new development. We also just recently used this new technology. It's called BrainSense. And what this allows us to do is basically sense the activity within the brain, and then that allows me as a programmer to look at what the brain activity is and adjust the settings accordingly. I was going to tell you about COVID and the COVID environment, and I think Parkinson's is a progressive condition, so patients need to be seen. Telemedicine we have offered to some patients, but it's very difficult for me as a physician to get an assessment just on a Zoom call or through a FaceTime and so on. So we do like our patients to come in to be examined, to see how they walk, to look at their muscle tone and the like. But we've taken extra precautions in terms of only permitting the patients and their spouse to be in the room. We have spread our visit slots quite a bit so that we don't have the big crowds that we would in the waiting rooms.